Hello. Hello, good morning. Hopefully, you got to see some of the pretty colors that were available for you over the last week. It's always cool. I think this happened last year, and then just to kind of see the sky and the northern lights and all the stuff to show up is always a treat, even as far down as down here. So that's pretty cool. So hopefully you got a chance to see the pretty colors. Also, if you haven't done so already, go sign up for my 450 class in the spring. Um, I know everybody's schedule is going to be a little bit different, but it's a good time to go ahead and get it out of the way, especially since we're piggybacking off of this class. It's good information to remember, and if you many of you have said that you want to go into this field and you want to learn what it is. So my 450 class is the diagnosis and treatment of substance use disorders. There are no discussion board posts. In fact, there are only 5 assignments, and there's a paper, but I'm reconsidering the paper. But there are only 5 assignments for the entire year, and then lectures. But no discussion board posts. It is very light on work. I mean, the work that you're doing is going to be different, so it's not quizzes and stuff. It's a little more applied skills. But it's a good class, and can really help to hone your ability to be a therapist or be a social worker or do this work. So if you haven't done so already, go ahead and get signed up, and that would be good. I would love to see you in the spring. All right, so let's talk about medication assisted treatment today. Sometimes can be a little bit controversial. It's gotten a lot better here recently. But there was a time, especially when I first started this class, that there was a little more pushback over medication assisted treatment. But the community as a whole is starting to be a little bit more accepting of it, which is good. So let's talk about it. And the biggest thing with it is medication assisted treatment, if utilized appropriately, can be the mechanism to provide a bridge between addiction and recovery. On the other hand, if it is not managed appropriately, it can elongate an individual's recovery process and runs the risk of enabling towards future or further use. Now, the biggest criticism early on that sometimes people will have about medication assisted treatment is that you're just trading one drug for another. And in theory, I guess that's true. However, that's not the argument that they're really trying to make. But the difference is that when somebody is engaged in medication assisted treatment, they're under the care of a medical professional that can help guide them towards whatever goal that they're looking for. It isn't that we're trading one drug for another. We're taking a drug that can be used to give people the chance to find recovery. Okay. So that's what medication assisted treatment is all about. We're going to talk about several of them today. We've got 5 different types of medication assisted treatment and 1 neurostimulator or neuromodulator. The main 3 that we'll be talking about are buprenorphine and or buprenorphine naloxone, otherwise known as Subutex or Suboxone. We'll talk about the difference as we go through. And these can be taken sublingually, transverse abdominally, meaning in the stomach, transdermal, and implantable. There's also methadone, which probably all of you are familiar with in some form or fashion. Oral and intramuscular naltrexone, otherwise known as Revia or Vivitrol. Antabuse, acamprosate, and the neurostimulator is called the bridge device. So let's start with, how do we know that someone, how do we dose someone appropriately for medication assisted treatment, if that's what they want to use, specifically with methadone and Suboxone? Well, in order to do that, we have to do what's called a clinical opiate withdrawal scale, otherwise known as a COWS. Now, there are some things about opiate withdrawal that you just can't fake. And so why is that so important? Well, your brain can only take so much Suboxone, and technically methadone as well. But But we don't just want to throw medication at you and hope for the best, because that could be enabling. That could be exactly what people are saying about trading one drug for another. Yeah, I mean, if somebody just comes in and we're throwing medicine at them without really taking into account a lot of the things that are unique to them, then yeah, I can kind of get that argument a little bit more. But the way that we're supposed to appropriately prescribe Suboxone or use methadone starts with a cow's. There are some things about withdrawal, opiate withdrawal, that you just can't fake. Okay. Um, Pulse rate, the anxiety somebody has, your stomach getting upset, what your pupils do. Like, there are some physiological signs of an opiate withdrawal that you just can't fake, right? We talked about the vital signs a few weeks ago, and this is similar to that. Like, there are things that you just can't go in and say, well, doc, I think I'm at 96.2 on the temperature. Like, you can't fake that. They are what they are. And so when somebody comes in going through withdrawal, we use a cow's to sort of figure out, all right, how much medication do they need? How much medication could they utilize in order to feel better? Or where do we start, in other words? So when a patient comes in and they're going through withdrawal and we're trying to decide what medication are we going to use, we start here. Now, the more withdrawal that they are in, the more or the higher these scores are going to be, for obvious reasons. So somebody coming in, if they've only used like 12 hours ago, they're probably not going to be going through a significant amount of withdrawal. This score could be pretty low. On the scale down here at the bottom, you can look at the score. They would probably be in like the low moderate range, maybe like a 20, 22, something like that. As they get into a full day, and certainly after 2 days, that this scale is going to go way up. And that's going to tell us, okay, this is where that patient is at. All right. So we start here, and then everything else cascades after that. So I start here because we're going to refer back to it as we go through. So let's start with methadone. So methadone was created in Germany around World War II to address an opium shortage. There was a belief that it was created by Hitler for mind control, but that's not true. What really happened was that the war really put a strain on the amount of pain pills and opiates that were available for the soldiers who were getting wounded. And so they needed to create something to keep their soldiers out there. Well, methadone would allow them to stay out there and would allow them to treat soldiers who were getting wounded. And since you could create it, you didn't have to worry about, since it was synthetic, you really didn't have to worry about there being a shortage. I mean, I guess you technically could, but you could ramp up production to make more. Okay. Basically, it's used as an analgesic to alleviate and relieve the symptoms of opiate withdrawal. It's really all that it is. And it acts as an agonist to prevent further use. We'll talk about what all that terminology means in just a second. The thing about methadone, though, is that it is very heavily federally regulated. So it's difficult to really get out there in big batches because of how highly addictive it is. So, and each state has different regulations as well. In fact, Kentucky is one of the most restrictive states for methadone in the entire country. Now, why is that? Well, again, every state is going to have its own regulations on this. And so Kentucky has taken the stance of like, we don't want to get these drugs out there because of obviously high abuse potential, trying to control a lot of the stuff. And because, in my opinion, the association that it has with people who use substances and the general negative connotation that that mentality brings, especially here in the state. It just recently happened that you could do like take homes for methadone. There was a time that you had to do daily dosing, and by and large, most patients will have to do that. However, There are now exceptions to where people can have take homes for like a week or 2 weeks based on the discretion. That didn't used to happen. So, how does methadone work? Well, here in Kentucky, people will have to get up and go every single day to get their daily dose of methadone. And we'll talk about let's do it here. So what'll happen is somebody goes in and they're in withdrawal, they're ready to get recovery, whatever. So they go to the one that's next to Journey Recovery Center is called Northern Kentucky Med, NKI Med, and what'll happen is a patient will go in, they'll say, I'm ready for recovery, and they'll give them a initial dose. So a big initial dose to relieve the withdrawal symptoms. Okay. And so they ramp it up to titrate back down because we want to make sure we're covering those receptor sites to where a patient doesn't go through withdrawal and the desire to use returns. So give them a big initial dose early and then slowly titrate them down. They have to go every day. And so they'll go, and it's $15 a day. So if you do the math, that's $450 a month. And they have to go every single day, and they're open from like, I think 5 o'clock to 2 o'clock or 6 o'clock to 2 o'clock. So they have to go really early in the morning. And they do that every day. And that's what keeps them well. Now, it comes in a couple forms. You've got your liquid here, which is the oral concentrate. And then you also have tablets. Now, the tablets are mostly utilized really outside of the state. I mean, we use them here, but they're more prevalent in other parts of the country. So like I was out in Arizona recently, and what Arizona does is they will have satellite offices. So because the state is so big and things are so rural, they will have satellite offices. So the main office will be in like Phoenix. And then someone who lives like 4 hours away from Phoenix struggles with addiction and they're ready to get treatment. Well, they can't just get to Phoenix all the time. That's 4 hours, but they can drive 2 hours once a month to go to a satellite clinic to where they meet with a doctor. There's a nurse there or a medical assistant, and then they meet with the doctor via telehealth or a nurse on a stick, the little rolly carts. And they'll do a drug screen, and they will get like a month's supply. Well, that wouldn't happen in Kentucky. We wouldn't do it that way. So for here, we will use the oral solution. Sometimes the tablets. The tablets are really for those take homes, those 3-day or 7-day take homes that somebody can use. So then the early introduction is we're going to get those withdrawal symptoms out of the way, and then we're going to go like 5 to 10 milligrams every couple hours to get you up to a dose that stabilizes you. That process is called induction. And so you will see that as we talk about this, also as we talk about Suboxone. Induction is basically how we're introducing you to the medication to where it, starts to stabilize in your system. Okay. So most patients are going to fall between 60 to 120 milligrams. Again, pay no attention to milligrams. Those are just like arbitrary numbers. They are relative to the medication itself, not relative to other medications. So like a standard dose of Suboxone is like 8 to 10 milligrams. It doesn't mean that a patient is getting more Suboxone than they are methadone or vice versa. It just means like that's the dose of the medication. Okay. So we want to get them stable. Now, patients can choose to stay here for a long time, or I should say for as long as they want. Sometimes patients will stay at a comfortable dose while they do treatment, while they go to groups, while they connect to others and start to live their life again. And that feels good. And then we're going to start to slowly titrate them down. Now, the titrations are very, very, very slow. Usually about 10% of whatever dose that they're on. So we're going to go, let's say we're on 100. We'll go 100 down to 90, maybe 90 down to 85, 85 to 80. Very, very slow. We're going to titrate you very slow. Okay. And the reason is because methadone will stick around in your system, and your body the body really likes it, and it has a very long half life, so it does take some time to get out of your system. Okay, it has a half life of around 4 to 6 days. Now, half life, if you don't know what that is the amount of time that it takes for half of the medication or half of the whatever substance to be eliminated from your body. Now, that doesn't mean that it can't have an effective dose. Half life dose and effective dose are two totally different things. But it's what is the amount of time that it takes for half of the medication to be eliminated from your body. Okay, eliminated from detectability. And so it can stay in your system for around 21 to 24 days, depending on your metabolism. We have 2 clinics in Northern Kentucky, NKY Med and Covington Metro New Seasons. And then there's one in Eastern Indiana, EITC, or Eastern Indiana Comprehensive Treatment Center. I don't know of any in Ohio. I have not heard of any that are close to me living here in Ohio. But that is methadone. Methadone, again, it gets a bad rap. It can actually be very effective for patients. In fact, there are some patients who, take methadone and they prefer it over Suboxone. Methadone can also be prescribed for patients that have chronic pain. They don't like that because you have to go every day, but it can be utilized for pain, and we're going to talk about that, and we're going to talk about those connections in a second. So let's talk about Suboxone. So the chemical name, or the pharmaceutical name, is buprenorphine for Subutex, and buprenorphine naloxone for Suboxone. Now, what's the difference? We'll talk about that in a second. So buprenorphine, or buprenorphine naloxone, is otherwise known as Subutex or Suboxone. Buprenorphine was created in 1966 to assist with the withdrawal from morphine. Again, we got war going on. It's around the time of Vietnam. There's a lot of things going on to where morphine is being utilized. And so buprenorphine was created to assist with the withdrawal from morphine, which is fine. But people would take their buprenorphine in the morning and then be able to get high by the end of the day just because of how it worked out. So they would go and they get their buprenorphine at 5, 6, 7 o'clock in the morning. By the time like late lunch rolled around, they could go get a little bit of heroin or a little bit of morphine and take it and get high. So in many ways, it kind of defeated the purpose of taking the medicine, if you want to think about it that way. So Suboxone was utilized in the 1980s in the UK to help with chronic pain, foreshadowing, but also to help with addiction. Okay. So let's talk about the different parts. Okay. So we talked about what an agonist is, right? So going back to this, acts as an agonist. So let's talk about how it works. Okay. So these little field goal looking things are your opiate receptor sites. And these are endogenous receptor sites in your brain. It's 8 o'clock in the morning. I'm working on coffee, so we'll get there. So you have these little receptor sites in your brain that are there to receive the opiates that you put in them. Okay. That's a nice little thing. So an agonist is a medication or a substance that mimics what a drug actually does. Okay. So methadone makes your brain think that you've got opiates. Okay. So the agonist mimics what the drug actually is. All right. And it makes our brain think, okay, cool, I've got the thing. A partial agonist does that a little bit, but then the opposite of that is an antagonist. So I'm sure you may remember from literature or your English class, like an antagonist is the character in the story or the force that works against the protagonist, right? So an antagonist will serve to block, as you can see here, right? It will block the receptor site, which makes anything, like if there is an opiate coming in, it would basically bounce off and not work. Okay. So antagonists are going to block the receptor site or work against. Okay. So if you have a partial agonist, or you could go the other way and say partial antagonist, when you have Suboxone, you get 8 milligrams of buprenorphine. Okay, just a standard 8 milligram. I'm pretty sure that's what this is. Yeah. So an 8 milligram, when you see this for buprenorphine naloxone, this is just Suboxone. Okay, you get 8 milligrams and 2 milligrams. So let's go back over here. So a partial agonist, they're going to get 8 milligrams of the buprenorphine, which is going to make your brain think, oh, cool, we've got our opiate, we're fine. But then you've also got this 2 milligrams of naloxone, which is the thing that will is a opioid reversal agent. You have this naloxone that kicks in that if they try to use, it kicks off the receptor site. So it's pretty cool. They get a little bit of both, right? Now, the difference between that and buprenorphine, otherwise known as Subutex, which is this guy right here, is, as you can see, buprenorphine sublingual tablet, 8 milligram. Sublingual film, 8 milligram, 2 milligram, right? So the 2 milligram is the naloxone, the 8 milligram is the buprenorphine. Down here, you don't have the naloxone, so there's not the blocker, okay? And that's the difference, okay? So buprenorphine we talked about, naloxone's an opiate blocker, opiate reversal agent. And then a partial agonist means that it acts as an opiate agonist while simultaneously serving as an antagonist in the same receptor site. So if you've got a patient that is still kind of shaky a little bit in their recovery, Subutex can work really well. Okay. Now, there are some patients in very rare cases that have an allergy to naloxone. And so you would have to stick with buprenorphine. But by and large, Suboxone works pretty well. So how do we utilize it? Okay. So talking about the induction. So what would happen at Journey Recovery Center is a patient would call and say, I'm ready for recovery. And we would say, okay, we need you to go through at least 24 hours of withdrawal, because if you're not in withdrawal, the medication that we give you is honestly not going to be effective. Like, we could give them and we're just kind of guessing. And we want to get them engaged in treatment. So if they were to come in and say, I need something, and we just give them 16 milligrams, would that do the trick? Yeah, sure, they'd be fine. But we might actually be giving them too much medication, and it would be generally ineffective. So we would want to do what's called induction. So we would tell them, we need you to go through at least 24 hours of withdrawal. Here recently, it's been closer to like 12 to 18 hours. I don't think our doctors love that, but that is kind of the change in the field, because they're trying to get people to care, which I understand. But so 24 to 48 hours, would prefer 48 because that gives us a better idea, but we also kind of don't want patients to suffer, so we understand that. So they would come in and we would do a COWS. Now, based on that score, we would start the dosing process. Okay. So if somebody is on a significant amount, if they're in a very high withdrawal, right, their score is very high, then we may start them a little bit higher than we otherwise would someone coming in moderate. Their initial dose would usually be like 4 milligrams, 6 milligrams, and we would check on them every so often and do another COWS score. So it could start out they could start out on 4 to 6 milligrams. And then let's say that we do, their starting dose was 4 to 6 milligrams. And then their starting COWS score was like, a 34. So the nurse comes in, does another COWS score after an hour and a half of them being on the medication, finds out, okay, their COWS hasn't really changed all that much. We're going to give them a little bit more. Okay. Then we'll check on them again. We'll wait 45 minutes, check on them again, give medication time to settle in. Now their COWS score is starting to come down. Okay. They're at their COWS score is now a 30. Okay. Well, maybe we do another 2 milligrams. Okay. So now we're at 10 and we wait 45 minutes and now their COWS is down to like a 26, 24. All right, let's hold this dose and see what the next one is. Well, if they keep going down and they get to a level that is mild or even low moderate, that's going to be the dose. We may up them by like another 2 milligrams just to be safe. But at that point, we say, all right, you're on 12 milligrams. Let's bring you back tomorrow. Okay, so that's day 2 induction. Okay, so you were on 12 yesterday. We're probably going to start you there when you come in and see what happens. And after you end day 2, that is the dose that you're going to start on, or that you're going to be on while you do your early recovery. Okay. So again, the goal is to just really get them introduced to the medicine, to find a dose that is stable. Now, they may go out in their job, or they may go out in the world and find out that, they're sweating a lot, they're using a lot of energy. It shouldn't have an impact, but it sometimes does, even just psychologically. And so we may have to bump it up to like 14 milligrams, or we may hold tight at 12. There's a finesse that comes along with the dosing, but you're really just looking for stability. Okay. After after day 2 induction. Okay. Once they get to their dose, they can stay on that for as long as they want. And then we'll start the titration process down. We usually go very slowly, 2 milligrams at a time every 6 to 8 weeks, such that patients can tolerate it. And sometimes that can be a little difficult to convince a patient to start the wean down because it's working. And that's okay. We don't have to kind of force it. We do want to respect patients' autonomy in that way. But I would always bring it up, like, okay, what are your thoughts on what does starting? Because nearly everyone that came into treatment wanted to be off of opiates altogether, but the thought of making that change was really hard. So if I didn't prompt it, or somebody didn't prompt it, they didn't really think about it all that much. So sometimes I would have to prompt the discussion of, like, what does your wean down process look like? Because sometimes they wouldn't do it. Okay. So Suboxone, buprenorphine naloxone, has a half-life of around 3 days. It can stay in your system for around 7 to 10 days, depending on metabolism. There are several treatment centers in Northern Kentucky. Journey Recovery Center obviously is going to be the one that is the most near and dear to my heart, and the one that I will recommend. But we also have Brightview, Ethan Health, Groups Recover Together. Sunrise Recovery is another one. Applegate was around for a while. So we've had several over the years, and there are several that are out there because the need is so great. The other thing that happened, either end of Trump's first presidency or the beginning of Biden, is that they allow for primary care providers to prescribe up to 20 patients without a waiver. Historically, you needed to get a waiver, a controlled substance prescribing waiver, to be able to prescribe Suboxone. But now you don't have to do that. Now they have given primary care offices, primary care doctors, the authority to prescribe 20, have 20 patients without a waiver. The waivers go from 20 to 100, and then I think they top out at 250 patients. But you have to take tests, and it takes time. So that is buprenorphine naloxone. Now, just focusing just on buprenorphine, we do have a couple of different types. So obviously, we talked about the sublingual film. Sublingual meaning under your tongue. Suboxone, Zubsolv are the main two. There's also the injection that's known as Sublocade. So basically, it's a 28-day dose of Suboxone that they put in your stomach, or Subutex buprenorphine that they put in your stomach. And so they would start here, and then they would just kind of rotate. And if you look real closely, you can kind of see the little bumps, right? So there's a little bump right there. There's a much bigger bump there. I think that's probably the guy's most recent. So their next one will probably go up here, right? But that is the way that they do it. They take a ice cube, and they'll basically numb that area, and then they'll stick you with it, and it lasts for 28 days, and it gradually wears off over time. The cool thing about buprenorphine, the Sublocade shot, is I've had a lot of patients that have been on it, and they don't have to, as they've taken it for a while, once they're ready to titrate off and wean off, there really isn't a lot of withdrawal. In fact, I had one patient who basically said, I've had no withdrawal, and she was on the shot for 6 years, I think, 5 years, and she finally came off of it, no withdrawal at all, and is just doing great. So so that's Sublocade. Ladies, you know this. Men, you probably don't, but there is a birth control that you can get in your bicep. They put it like right here. Um, well, you can also do that with buprenorphine. That's these little rods right here. Each one of those are 2 milligrams, and they put them in your bicep. They last for 6 months, called Probufene or Brixadi. They last for 6 months. We can do it twice, one in your left, one in your right, and then you're just kind of done. And it's really good, and it's great. And it's great for patients. It's not great for like actually doing the work of recovery. I was exposed. I had 3 patients that did it. The first one that did it, I told the team, they were like, "What do you think about this patient doing the implant?" And I said, "Well, I think it's great for her, but I also think we're never going to see her. We won't see her again for 6 months." And they go, "Oh no, she'll engage in the other stuff. It's just so great." Like, no, she won't. She doesn't have to. She's not going to show back up. Well, she got the implants. She came back for one more session, and the treatment team rubbed it in my face like, "Oh, I thought she wasn't going to come back." And then we never saw her again. So the implants are great for people who are very busy, who don't want to take something every day, blah, 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 blah. But it does get in the way of them actually doing the recovery work. It's a little bit of a carrot and a stick sometimes with this kind of stuff. Like it's not just about the medication. There's a whole other level of recovery work that needs to be done to fully stabilize, someone. And that's kind of the little game that gets played in a lot of these recovery centers, which is, the patients don't really always want to come in for the therapy and the groups and for as great as I am as a therapist, I'm not going to be able to stop somebody from going through withdrawal. That's what the medicine's for. And so it's a delicate dance that gets a little weird from time to time. But the implants can really help somebody to have that autonomy back in their life, and it's really great. Genuinely, it's good. Then there's also the transdermal patches, which is the Butrans patch. Now we do have that for like cancer patients. Fentanyl patches can work, but also this also has buprenorphine in it, which can help with managing opiate addiction and withdrawal. Those are the different types. Neat, huh? Can someone go from methadone to Suboxone is a question that would often happen. Yeah, sure. So if a patient, like if you go to a methadone clinic, that doesn't mean you're locked into that forever, but you do have to be under 30 milligrams of methadone for 30 days. Okay. And that would be kind of the big barrier that I would find when patients would call and they would say, "Hey, I'm going to Northern Kentucky Med, I want to come and do Suboxone." And I would say, "What milligram are you on?" And they were like 110. And I went, "Oh boy." So I would tell them, "All right, well, you need to titrate down to under 30 milligrams. "Well, I don't want to do that." I'm like, "Well, we can't just give you Suboxone with that much methadone." And unfortunately, that patient wouldn't be able to come in. Or what if I just stopped taking methadone? I'm like, "Well, I can't recommend that. I can't recommend that." And we would, obviously in your history and your background, we would kind of see that. So don't do that because I can't recommend that. And that would kind of be a little bit of a deterrent for somebody to go to come to treatment. But that's also the medically appropriate way of handling that. But in general, the reverse doesn't have these considerations. So if a patient's on Suboxone and they're going over to methadone, they don't have to be on a particular milligram. So just kind of go. So now we have oral and intramuscular naltrexone. These were developed in the mid 80s, and they serve as an opiate antagonist. Remember, that's the blocker. Okay. And it blocks the opiate receptor site. So intramuscular naltrexone, otherwise known as Vivitrol, which is there on the bottom, was approved to treat alcohol use disorder in 2006 and was approved to treat opiate use disorder in 2011. With alcohol use disorder, AUD, we can utilize it in the same day. So if a patient is struggling with alcohol use disorder and they want to get treatment, we can give them these medications on that same day. With opiate use disorder, we cannot. They have to have completed withdrawal before we utilize these medications. The reason being is because they have a higher affinity for the receptor site than the actual drug itself. So what ends up happening is that if somebody has recently used an opiate, you give them Vivitrol, it will pull that out of the receptor site and then cap the receptor site to where opiates can't get back in. Now, whoa, well, what's the big deal? That sounds great. No, because they're going to go into severe withdrawal basically within like 15 minutes. And it happens that quickly. I had a patient who was on. So what happens sometimes is that we would give a patient Vivitrol and we would schedule their injection on either like day 26, 27, 28. Well, sometimes because of the weekend, and we don't want to give it too early, but sometimes because of scheduling, because of the weekend, whatever, it would end up that it would actually get scheduled on day 29, 30, or 31, something like that. And so we would give them oral naltrexone in order to bridge them over. So if it's day 28, in people's metabolism, Vivitrol can start wearing off because it's 28 days, but it can start wearing off on like day 23. But patients don't really feel it because they kind of normalized, and most patients won't test those waters, but some will. But day 23, 24, 25, I mean, it can start wearing down. And so we give them the oral naltrexone to bridge them over. Well, had a patient once who they were coming in on day like 31 and their mom was the one driving them. And so what they had not told their mom is that they had actually used heroin the night before. I was seeing them on Monday morning to get there. I was seeing them at 8 to get their injection at 9. And then so they had actually used on Sunday night and did not tell their mom, did not tell anybody. And so they needed to take their pill in the morning to do the little bridge, right? So they took their pill, and right before they walked in the door, I pull them back at 8. By 8:05, he is shaking uncontrollably and sweating. By 8:10, I'm getting a garbage can for him to throw up into, and the shakes are much worse. By 8:15, he is in one of the exam rooms with one of our warming blankets and vomiting, shaking, anxiety, and by 8:30 he was carted and taken to the hospital because he was in opioid withdrawal because he had been using, right? So with Suboxone, we need about 7 to 10 days. We prefer closer to 10. With methadone, 10 to 14. With opiates in general, that 7-day mark is pretty good, 7 to 10. We can go as early as 3 days, 4 days, but we have patients sign a waiver saying that like they don't hold us in, like it's called a hold harmless, so they won't sue us. So yeah, oral naltrexone's great. And Vivitrol is really good too. With alcohol use disorder, we get varying results. I mean, it can really help people, but some people find that it actually doesn't do anything for them. So they'll get the injection, but then they'll go drink and get drunk, and it doesn't really do a whole lot in that space for some patients, not all. All right. So if those things don't work, especially for alcohol use disorder, what can somebody use? Well, we have Antabuse, otherwise known as dalsulfiram, and it is used to treat alcohol use disorder. It's taken daily, and just with taking it, smelling alcohol can make somebody nauseous. And if they actually drink alcohol, it leads to them feeling overwhelmingly sick. Like, what am I doing with my life? Kind of sick. So it is a big deterrent for patients to not drink. Now, the challenge with this and the oral naltrexone is you do have to take it every day. If you skip a dose or skip a day, you can go get drunk and it's fine. So, or you can go drink and it's fine. So you have to be consistent taking the dose every day. That's the key. Okay. We also have another medication called Campril or a Camprosate, and what it does is it targets the neurotransmitters in your brain that says drink more. Used alone, it's kind of ineffective, but alongside counseling, it has shown to be just as effective as naltrexone. Okay, so it's actually very, very good. And we usually, if we're looking at the patients that struggle with alcohol use disorder, we try to use antabuse as a as a last resort, right? This one is a last resort. Campril can help with the signaling to target the those, as I said, those things in your brain that say, hey, you need to drink, that impulsivity stuff. So we are usually, our first line is oral or intramuscular naltrexone. The Vivitrol shot can be pretty pricey for patients that are on private insurance. It can be about $650 to $700 a shot, and that's with a copay card and with coupons, and so that can get a little pricey. So we use the oral naltrexone stuff, which it works just the same, but again, you have to take it every day. Same thing here, you have to take it every day. If you miss a dose, then it doesn't work. Okay, cool. Let's talk about the bridge device. So it is referred to as a neurostimulator. Okay. And one last thing about Campril and any of these medications. One of the things that you're going to see is that a patient will come in and what they're looking for is a medication that takes the thought of drinking away. That doesn't exist. And patients can get really frustrated because they want to take something that makes all of these things go away to where they don't really have to do a ton of the work. That would be nice, but it doesn't exist. So setting patient expectations appropriately can be helpful. Bridge device, so is referred to as a neurostimulator. Okay. Basically what it does is you have to be going through withdrawal for it to work. There are 4 cranial nerves that it targets, and it sends an electrical impulse to the areas of your brain responsible for withdrawal. In other words, as somebody goes through withdrawal, there is chemical signaling that says, hey, withdrawal. What the bridge device does is it sends a countercurrent in the other direction to basically tell your brain, no, it's not, we're good. So if you're not going through withdrawal, it doesn't have anything to sense. And if it doesn't have anything to sense, then it doesn't work. Okay. So the four cranial nerves that it targets here, 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 and then there's one on the back. You can see this little wire going here. It's going to the back of the ear. And then you have this little computer chip that sits right here. It's got a sticky back on the back of the little casing. Patients wear it for 5 days, remove it on the 6th, and physiologically, a patient is through their withdrawal. Now, this sounds like science fiction, and in many ways it literally kind of is, but it works, and I've seen it work. I had a guy who was a big, like, construction worker dude, like 250 pounds, big dude. And he came in and he was basically like on his knees at our front desk in withdrawal. Like I'm going through it. And I told him, I said, I was working the front desk at that time. And I told him, I said, look, if once you do this bridge device, you're going to come meet with me for therapy afterwards and you're going to feel fine. And I got a lot to lose because if I'm wrong, he's never going to trust me. But he walked into my office after getting the bridge device and he looked like a different person. It was an absolute miracle for him. And so he wore it for 5 days. We took it off on the 6th. We never saw him again, but we never saw him again. So my hope is that he was able to stay in his recovery, but it works and it's great. The bridge device is actually really, really cool. Now it is, again, pricey, but it's very, very good. So let's talk about a few other considerations as we wrap up today. Do we do Suboxone long-term or do we do it short-term? Is it forever? Or what do we want to do with it? And how do we utilize that? There's nothing saying that a patient has to come off of this medication, but it's kind of nice to be off of the medication. So how do we work with patients to promote, maybe you could live a life opiate-free? What does that sound like? Suboxone is not for pain management. Now, you may have a lot of patients who will say, I took one of them Suboxones from a friend of mine and it really helped with my pain. Yeah, it's an opiate. That's what it's going to do, but it's not for pain management. And so we get a lot of frustrated patients coming from a pain clinic because they don't want to be on their pain pills anymore. But they still have pain. So what do you do with that group? Okay. Also, Suboxone and benzos, Xanax, Klonopin, Valium, etc., are not good bedfellows. They do not work well together. And it actually takes a specialized addiction, board certified addictionologist to be able to prescribe both of them at the same time. Okay. Because they do not mesh well together. Sometimes patients really like that combination, but they do not work. They do not go well together. And then also daily dosing, as I mentioned with pain medication. Um, if a patient wants to come off of pain pills, great. Do we look at daily dosing? Do we look at how can we stabilize them through that in order to get them to a better place of wellness? Okay. By the way, I did not mention it this week, but I have been. We're going to San Diego, and I'm going to go play golf at Torrey Pines, which is like a PGA Tour venue, and so I'm looking really, really forward to it. So that's your code word this week is golf, GOLF or GOLPH, GAWLPH, however you want to frame it. Golf. That's your code word for this week. Cool. As always, Canadian geese are definitive proof that evil exists. Live mahalo. I will see you next time. Okay, bye.